My name is Christian Long. I'm the Vice President of Contracting and the ACO Executive for Complete Health. Medicare itself has traditionally been what your mother, grandmother, grandfather may have had in the past, where they enroll in a program with the government, pay a slight premium every month, and see pretty much any Medicare doctor they choose. That traditional Medicare has been around for obviously many, many years. But over the last 30 years, commercial payers have gotten into the game. People such as Humana, Cigna, and United Healthcare, and they've created Medicare Advantage. They work with the government to offer enhanced benefits over your traditional Medicare and at a cheaper cost to the patient. And with that, there's opportunity to offer patients enhanced supplemental benefits such as dental and vision care, gym memberships, and so on. Overall, Medicare Advantage growth over the past 30 years has been significant. This is due to the aging population and due to the fact that the commercial payers such as Humana, United, and Cigna have invested a lot of marketing dollars into the program. With the growing population of Medicare Advantage, it creates more opportunities for Complete Health to grow and better serve this population. When we look back at the reimbursement methodologies is where the whole value-based care begins. Traditional fee-for-service Medicare is what most doctors in the country currently participate in. When a senior sees a doctor, the doctor files a claim with the government, and the government pays them $120, $140 for that visit. Next is capitation, and that requires a little more sophistication by a provider. A provider receives a monthly flat payment every month for a particular Medicare member, regardless whether that member comes into the primary care office or not. With that payment, there's less administrative burden, less billing cycle delays. It's an upfront payment and it gives the provider a little bit more of a margin on their payment and a little bit of incentive for spending more time with the patient and investing in their care. Next on the evolution is value-based care. This is where it gets good. This is where Complete Health is focusing. It's where the Medicare Advantage payer, again like Humana, United, Cigna, will actually start paying the doctor bonuses if they beat certain cost savings targets and produce higher quality results. This could be a flat $100 bonus per patient. It could be a $10,000 payment at the end of the year. It varies by the payer and the population. Next on our evolution is shared savings. And here there's a cost target determined by the Medicare Advantage payer in conjunction with the providers, and that cost target must be beat. If that target is beat, any money below that is savings, and that is split between the provider and the payer. Great opportunity. Now, the fun part, the Complete Health specialty, which is full risk. Here the payer gives us a pool of money, and we're responsible for the entire expense of that healthcare or that senior citizen. Every hospital visit, every specialist visit, prescription, crutches, ER visits, that is something that we at Complete Health are fully responsible for. We do not pay those claims, but there's a ledger. Here at Complete Health, we solely focus on the FAR 3 reimbursement methodologies. Now, this is a transitional methodology as well. With any new payer, any new market we go into, we start with the value-based care payment, move to shared savings, and hopefully within 1 year, if we get the right amount of population under care, we'll be in full risk. Now, what are the differences between the value-based care shared savings and full risk? Value-based care shared savings, there are bonuses. Could be the flat dollar bonus or a percentage savings bonus if we meet certain quality metrics and cost-saving targets. But full risk, of course, we're 100% responsible for every healthcare expense that patient incurs. Value-based care and risk involves two components, income and expense. The income side is called the payer premium. That's the pool of money that Complete Health receives to pay our doctors and to pay medical claims out of. The expense part is any medical claim incurred. Now, Complete Health does not receive that premium money. It is actually on a ledger within the payer's financial statements. They hold that money for us, and as they pay claims out to the hospital, to the specialist, to the ER, they deduct from that ledger. The full CMS burden cost for an average patient is $1,400. Now, if we have a pool of 5,000 patients with a Medicare Advantage plan, you can see that's a total of $7 million for us to work within. That premium then is discounted by $1 million approximately for CMS to realize savings in the program. That leaves only $6 million for the payer to manage the healthcare lives of those 5,000 patients. The payer contracts with Complete Health. They take out their admin costs, which here is approximately $900,000. That pays for the health plan's marketing, building physician networks, contracts, customer service, and enhanced benefits such as gym membership and vision and such, leaving a $5.1 million pool left for Complete Health. Now that is put into a ledger by the payer, and as claims come in for that service month, they deduct from that $5.1 million. For this pool of people, there were approximately $2 million in hospital claims. There was $1.5 million in specialist visits and another $1 million in various other healthcare expenses. That shows that the $5.1 million received, we have actually achieved a surplus of $600,000. And that is how we create revenue and value for our organization. Now we want to talk about ACOs. You'll hear the word ACO quite a lot. And you can almost think of ACO as just another version of the same Medicare Advantage risk model that I went through earlier. With an ACO, there are three components. Capitation. CMS gives us money upfront every month for administrative and paying our primary care providers to take care of those patients. Then we have a benchmark. The benchmark is a cost target for the overall population over a given year. If we have 10,000 lives within our ACO, there'll be a benchmark for the total cost expected by CMS for us to spend on those patients over that 12 months. And last, we have the surplus or deficit. Once CMS closes out a financial year, they look at all the claims expenses, again, inpatient, specialists, pharmaceutical, drugs, ER visits, urgent care, and they look, did we beat the target? If we did, great, surplus. If we did not, deficit. That cost overage is money we pay back as a penalty to CMS. You can see that the risk and reward is actually increasing from the left to the right. Let's look at the risk side first, the red bars. For each path you can choose, you decide how much risk you're willing to take. It could be as little as 0% downside risk, all the way up to 100% downside risk. On the reward side, if we perform well the benchmark, we can realize 40% of those savings we achieved, or all the way up to 100%. Complete Health solely works in the far right ACO REACH program, where at full risk, we retain all savings or we pay back all losses to the government. The traditional Medicare cost for a patient is $16,000 a year. Now, CMS factors in savings for the ACO off the top. They take out $2,500 to realize savings to help CMS maintain budget compliance. That leaves a benchmark of $13,500. That's the pool of money we're working for an entire year for one patient. And if we close out the year and a patient only has $12,750 in expenses, you'll see that green box is $750 we realize in savings for that patient. Across 5,000 patients in our ACO, you can see that can be a $3.75 million surplus for Complete Health. Excellent. That's a good year. But there's a downside. If we actually do a poor job of managing our patients, we do not manage their chronic conditions, we do not intervene on their conditions, we do not see them often enough, they end up in the hospital, cost overruns, and so on. You'll see that average cost could be $15,000, and that red box is the deficit. $1,500 over the benchmark times 5,000 patients, we have to basically pay the government $7.5 million as our penalty. The $3.75 million surplus is realistic, and since 2021, when we launched our ACO, we've achieved savings surplus every year. But that $3.75 million in the prior example is not pure profit for the organization. It is a very expensive venture to launch an ACO. For example, we have to put up $8 million in annual financial guarantees with the government. It's a heavy investment in our care management programs, all required by Medicare. PCPs are the lowest paid physician in the healthcare system, yet they control the majority of the healthcare expenditures and have the most influence on the overall care and outcomes of a patient. We have a heavy investment in our primary care model between the primary care doctors and the nurse practitioners that support them, plus our medical assistants. We have a large staff of care management nurses that interact with chronic care patients on a regular basis to make sure they're adhering to their medication, following their care plan, and improving their overall health. Now, with all this money being thrown around, you wonder, where is it coming from? We're not creating new money. Surely this money is coming from someone else. Are we taking more money from the government? No. We are actually saving the government money by enrolling in a Medicare Advantage or an ACO. Are we taking more money from the patients? No, the contrary. We're actually saving our patients money. Through these models, many of these patients, we can waive their copay or co-insurance costs, making it easier to access care, especially for those on a limited or fixed budget. Are we providing less care for our patients? Absolutely not. These are highly regulated programs by the government and Medicare Advantage organizations that require meticulous coding and reporting of quality data. We have to continually prove to the government and the providers that we are achieving better outcomes with our patients, higher quality adherence, better care plans, and keep them healthy, happy, and at home. And are we paying our providers and employees less money? No. As I mentioned earlier, primary care doctors are some of the lowest paid physicians in the healthcare system, but through this program we create more value for them, putting them back in the spotlight of truly directing the care and receiving some additional funds they truly deserve. Now, where does the money come from? 20 to 35% of all hospitalizations are unnecessary, and a hospitalization can cost thousands upon thousands of dollars a day. ER visits, 66% of the people who go to the ER should not be in the ER. It's something that could have easily been handled by an urgent care center or by their primary care physician. Medications. Well, yes, most medications are generic now thanks to our programs, saving 70% off the brand name drug cost. And lastly, specialists. Through our better care coordination of our primary care physicians, specialists are chosen on quality, and we follow up and work collaboratively with the specialists, meaning less specialist visits, and we focus on higher quality specialists who are more effective in treating the care. Between those four categories, you can see the savings creates that extra revenue that comes into Complete Health. That is your boot camp on value-based care. You'll find me in the employee directory. I'm happy to talk to anyone about ACO, Medicare Advantage risk, or any other payer network